chairman of anesthesia at Grand Strand Medical Center in Myrtle Beach, level 1 trauma center, supplying trauma care in the downstate. And I'm also the anesthesia residency program director of our second anesthesia residency in South Carolina, which was inaugurated just 6 months ago. This young woman with me is Dr. Tiffany Aiken. She is a Greenville native, a graduate of Furman University and of the University of South Carolina School of Medicine, and she is a first-year anesthesia resident, and she is here to tell you a little bit about her training and education as an anesthesia resident. Before I let her do that, let me say that for a number of years, I taught student registered nurse anesthetists as a faculty member at the Kaiser School of Nurse Anesthesia in Los Angeles. I was also a site director where those SRNAs to become CRNAs trained. I have for the last 5 years trained physician graduates and anesthesia residents to be, and I'm here to tell you that there is a huge difference between the training a SRNA receives and the training that an anesthesia resident receives. Dr. Aiken, if you'll permit me, would be happy to explain the extent of the training and experience that she has had so far and will have.
Thank you, Madam Chair. My name is Dr. Tiffany Aiken. I'm a first-year resident at Grand Strand Medical Center. I was asked to talk about my training to this point. From day one, we are trained to be independent decision makers. It's incorporated into our curriculum from the very start. Medical school, is first 2 years are preclinical years of basic science, learning the normal functioning of the body, what happens when it goes wrong, and how we correct it. Last 2 years are actually clinical patient contact of 52 weeks, on average 60 hours a week that we're in contact with patients for a total of 6,240 hours. When we start intern year, another 52 weeks, averaging 60 hours a week, so that's an additional 3,120 hours of patient contact. And we are refining those skills to be an independent clinical decision maker. Clinical anesthesia years is another 3 years. 52 weeks times an average 60 weeks times 3 years. That gives you a total of 9,360 hours that we're practicing independent clinical decision making specific to anesthesia. We do several months rotating through various anesthesia subspecialties, again, focusing on that specific anesthesia requirements for that patient population. Examinations, we take a total of 9 exams to become independent practitioners, totaling 51 hours of just taking the exam, not studying for the exams, sitting for these exams. All of these exams are actually testing our ability to make these decisions independently based on evidence-based medicine. A journal article from the American Association of Nurse Anesthetists in 2017 states that CRNA's average years of experience prior to going to CRNA school is 2.9 years, or 6,032 hours of critical care experience, but that experience is not as an independent practitioner. Any decisions that have to be made come from the physician, whether it's a resident physician or attending supervising physician. They don't make any independent decisions. So their first experience in making these independent decisions is while they're training as a CRNA. On the published website for the University of South Carolina CRNA program, they say 28 months of training, including 1 8-hour day working with patients during that training. MUSC's CRNA program, 36 months in total. 18 months of that is in the clinical setting, averaging 36 and 40 hours per week. Their clinical setting could be either patient contact, simulation lab, or clinical presentations. So as Dr. Pesci stated, there is a significant difference between the type and length of training between physicians and CRNAs.
And your training is for
anesthesiologist.
Anesthesiologist,
Yes,
okay.
ma'am.
Are there any questions? Thank you. Dr. Vince,
Degenhart.
say that again?
Degenhart. Vince Degenhart.
Okay.
Thank you, Madam Chairman. I'm Dr. Vince Degenhart, practicing anesthesiologist, practiced in South Carolina for almost 40 years. I just recently hung up my stethoscope as of January 1st. From Florence, as I said, after graduating from Clendenin High School, I attended the Air Force Academy, transferred to the University of South Carolina, 1973, graduated from USC, went to medical school, graduated in 1977. Then I did an internship in New Orleans and did general practice in Clio and Bennettsville, South Carolina for 2 years. And then went back and did my anesthesia residency in Charleston, finished in 1982. So there are about 14 years of formal education past high school. I've worked with nurse anesthetists and anesthesiologists in South Carolina, as I said, for almost 40 years. Literally hundreds of nurse anesthetists and anesthesiologists, both highly trained, highly skilled professionals. I've worked in the anesthesia care team, and I've worked as an anesthesiologist doing solo cases on my own. And I firmly believe the anesthesia care team is the safest way to deliver anesthesia in this state. And it is a stated goal of the American Society of Anesthesia that all anesthesia given in the United States have an anesthesiologist involved. We realize there are not enough anesthesiologists in this country to do that. However, that is a laudable goal, and it is a safety goal. In spite of what's been said, although anesthesia, and we strive to make anesthesia safe and safer every day, anesthesia is a dangerous business. It's a dangerous profession. Things that are done wrong or omitted or should be done, not done, those mistakes can result in death. And in fact, they do. And not just death, even which may be considered worse, brain damage, nerve damage, patients are maimed. And this happens, unfortunately, all over the country, but it's fortunately very rare. Approximately 1 in 100,000 patients have an anesthetic mishap, an anesthetic death, in fact. Over 300 patients die in the United States each year from anesthesia. I've helped defend anesthesiologists and CRNAs in malpractice cases for the past 35 years in South Carolina. And one misnomer I think that's been stated is that if this law were to go into effect, that the surgeon working with an anesthetist, that they're no longer, quote, supervising or medically directing, that the surgeon or the dentist or the endoscopist would not be medical legally responsible for that anesthetic. Well, I beg to differ. In every case that I've testified in South Carolina, the surgeon, the endoscopist, the operating physician has also been sued along with the CRNA and the anesthesiologist. Why are CRNA's malpractice rates so much lower than anesthesiologists? Because the anesthesiologists are the deep pocket. So we pay a higher rate, we have higher levels of liability, usually 1 million, 3 million. CRNAs often have lower, and their rates are much lower, and oftentimes they're dropped from the cases because the anesthesiologist ends up being considered the captain of the ship and directing the anesthetic. A few more minutes on personal experience. Just in the last month, 1 month ago, I practiced in Camden for the last 15 years. We had a patient that had a relatively minor procedure, excellent CRNA. Did the anesthetic with one of my partners. I took over the patient in the recovery room as I was on call that evening. Patient was apparently had no problems under anesthesia, but in the recovery room, blood pressure was a little bit low, responded to some fluids. We were able to send the patient to the outpatient recovery area, but I said I wanted to see that patient before they left. The nurse called me, came to see the patient. She said she felt a little bit short of breath, although her oxygen saturation was acceptable in the mid-90s. But she's 78 years old. She walked across the room, and her daughter says, you know, this is different from mom. This is a little different. She really followed all the parameters, within parameters, that we could send her home. But I didn't feel good about it. I said, let's just get a chest x-ray and see. The chest x-ray showed she had a large left pleural effusion. Was not known beforehand. We didn't know why she had a pleural effusion. I called the hospitalist because that's the protocol now. The hospitalists admit patients for the surgeons after hours. And so this patient was admitted to the hospital service. A nurse practitioner took over the patient. We ordered a CT scan and admitted the patient to the hospital. Several hours later, still concerned about this patient, I went and looked at her chart. CT scan showed that this was a hemothorax, blood in the chest. This was a surgical complication that went unrecognized. A trocar, a large needle, was used to thread a catheter in this patient's back and for a spinal cord stimulator, and she bled into her chest. She was still short of breath. She was painful. I went to see her. I called the surgeon at 11 o'clock at night, and I said, this patient needs a chest tube. We put a chest tube in this patient at 2 a.m., took 2 liters of blood off of her chest. Now, was it fortuitous that I was there? We take call, we stay in the hospital. Yeah, I think it was.
Sir, we need to kind of wrap it up.
All right. And I think because of my background and because of that I had that experience, there was no CRNA there, that we were able to get this patient home safely 2 days later. And I'll close by making this one statement, and I would ask each of you on this committee. If it's your family, do you want a doctor, a physician, preferably an anesthesiologist involved in the care of your family, your mother, your father, your children, or yourself? Thank you.
Thank you.